at the hotel here at 6 o'clock last night to find the power off. And so the power was off most of the night. And so his room was on the 6th floor, no elevator. And so, but they gave him the keys, the locked the battery powered, so he trudged his suitcase up to the 6th floor and stayed in the dark for a couple of hours until he finally figured that this wasn't going to work. So he said, okay. So he found another hotel and came back. And then this morning he finds out that the boxes which were delivered here, which have all the stuff for this morning, were not here. And I don't know what happened to the boxes. They were signed for, but now they're not here, so they're doing that search to find out the stuff for it. And I want you to notice his face. Everybody trying to look at Dr. Strong's face. That's what I want you to appreciate about him. He is the nicest guy you'll ever meet. And he's always happy. He's always encouraging. He's always got a smile. Even if he's got a little frustrated. I've known him since dental school. And we were in dental school in DC a long time ago. And even in dental school, he was a terrific guy. He's been doing implant restorative dentistry since we started doing implant restorative dentistry. Back before we had YouTube so that we could figure out how to do everything, or before we had cell phones and internet so that we could look and see stuff. He was on his own. And he taught himself well. But one place that I want to emphasize to you, the reason why I'm so excited that he can be a part of this program, is that his business management style related to general practice in general and related to implant restorative dentistry in a general practice is par excellence. And he's going to talk with you about that, and I hope that you'll incorporate it. When I got out of the Air Force and started private practice in Fort Worth, I heard Sam talk very near that same time period. And I model my practice in many ways and what he talks about. Sam's wife is very active in his practice. She also related to dental practice. And my wife and I were a team in my practice. For those of you that think that you can't work with your spouse, we are two examples that sometimes you can, because for both of us it was a very good experience. But at any rate, I model my practice, I model the way I do fees after the way Sam showed me how to do it in that lecture. And I hope that you'll do the same because it works very well. Sam's from Little Rock. We won't hold that against you. I actually didn't mean anything anymore since Southwest Conference. I went to a Arkansas game a couple of years ago, and the students weren't even very excited. There's something wrong in the world. But Sam Strong, and notice I have not once this morning called you Sam. Because that's the way I've known, my whole life. I've known him as Sammy. But at any rate, Sam Strong, take it over, man.
Thank you. Thank you very much, Dr. Haney. We have known each other a long time, and it's been a wonderful relationship, and have great respect for the institution here and what Dr. Haney has done here with the program. It's a great program, and I've been privileged to work with the program for many years, so I know that you're going to gain a tremendous amount of information and knowledge and be able to carry that back to your practices. Just a little bit, just to amplify, I am a general dentist. I've had a general practice in Little Rock, Arkansas for 40 years. We graduated from Baylor in in 74. Spent a couple of years in the Navy in California, and then back to Little Rock. And I focused on implants since the late 80s and early 90s. And most of the time during that period of time, I focused on the prosthetics part of implants. However, for the last decade or so, I have done some of the surgical work. I still work primarily, most of my cases are done in conjunction with my surgical colleagues. But I do enjoy placing implants, and I cherry-picked some of mine because I got into the game a little after grafting had gotten going. So I don't do huge grafts, but I do some grafts and place implants for singles, multiples, and overdentures. All 4 cases are done in conjunction with my oral surgeon because I've had such good results with my surgeon that I just decided not to rock that boat. It's kind of interesting, when I first started the implants, I was working with a different surgeon who very much discouraged me from doing the surgery. It kind of took a dim view of that. So I thought, that's okay because I've got my hands full with prosthetics anyway. But I think for you all, we can say you all down here, can't we? for you all, and your careers, no doubt you're going to be doing much more of the surgical procedures than I did. Okay, feel free to ask questions at any time. I'll stop, and then if you have any questions at the break that I need to address, then I can come back and get them after the break or after lunch. The plan was to have a workshop toward the end of the morning program. And I set boxes down, and they were supposedly arrived Wednesday, and now they've vanished. So we're working on that. So I'll do the lecture, and we'll see what happens with boxes. If we get them in time, then we'll still do the workshop. I was thinking, if worst case scenario, if we can't get the materials, I certainly have the slides that we would take you through on the workshop, because it's a very important part of what you're going to do for hybrids or all-on-fours, and that is the impression technique in order to get an accurate master cast for your all-on-four or your hybrids, because you have to make that framework fit. And I'm sure you've already been through this to some degree, but that's the critical part. I liken going from single implants and multiple implants, crowns, and overdentures even, going from that mix of implants and then jumping to all-on-four is kind of like going from the junior varsity to the NFL. Because now things get really precise. And if we mess it up, it's a huge financial mistake on our part that we have to make up for. So it's critical that that master cast be accurate. Overdentures, obviously we want to be accurate too, but the overdentures are the most forgiving type of implant dentistry that you will do, because you're going to be able to set those attachments in the mouth. You're not having to make a framework fit. Okay, that's Little Rock. Looking across the Arkansas River. Beautiful little town, 175,000. If you ever get an opportunity to come up there and take a look or a vacation in Arkansas, the state's beautiful, particularly from the central part of the state, Little Rock, all the way up to the northwest corner where Fayetteville, Springdale, and Bentonville are. Of course, our football team is just awful this year, so we're not real happy about that whole situation up there. But we stole the SMU coach, and maybe we're going to get better. Regardless of that, I went to school, I graduated from college at the University of Arkansas, Fayetteville, and it is one of the most beautiful areas in the central United States. The Ozark Mountains are the tallest mountains between the Appalachians and the Rocky Mountains. So it's really pretty. Also up to the southern part of Missouri, if you're traveling for some vacation or whatever. Okay. Every 8 seconds, somebody in the United States turns 65 years of age, and that happened to me a few years ago. And I feel that situation. Now we're on Medicare, we're dealing with all that kind of insurance milieu. I think that you and I have a good 20 years of productive work to do on the baby boomers, because those baby boomers, as they turn to the late 60s, into the 70s, 80s, and even beyond, do not want to have just plain dentures if they can afford it. And a lot of them can afford something better, and a lot of them are healthy enough to be able to enjoy good implant dentistry. I'll show you a case later today of an 88-year-old lady. She's now 92, upper and lower all-on-fours. So age is not necessarily, it's not at all, a contraindication to being able to do good implant dentistry. I think there's a lot of fertile area for us to deal with. What I wanted to deal with through this program was treating the edentulous patient. I have one other little new thing I'd like to share with you for fixed bridge work on implants, our screw retain. But those are basically our general options: bar overdentures, locator overdentures, and all-on-fours. I use locator overdenture kind of like we talk about, I'm going to go get a Coke. You could have lots of different kinds of attachments other than just a locator. You can have O-rings, ERAs, there's scads and attachments out there. But worldwide, the locator attachment has been the big selling gun for the last couple of decades. So when I use that term, locator overdenture, I'm referring to an overdenture without splinted implants, non-splinted, using locator attachments or any other attachment that you or your lab might recommend. I'm really not going to deal with bar overdentures today because I don't do very many bar overdentures anymore. We tend to do locator unsplinted implants, or we tend to do all-on-4s, at least in my practice. And I would just use this opportunity to note to you that the bar overdenture and the all-on-4 basically have the same types of appointments when you and I go through. The bar overdenture will be the most costly appliance that you will make. It will cost you more to do a bar overdenture than it will cost you to do an all-on-4. Because you're still making a milled bar, but then in addition to that, for the bar overdenture, now you're having to mill in receptacles for your metal housing, for your buttons, and then for your attachments. So you buy, on top of the bar, you buy the attachments and all its accoutrements. And then, of course, the all-on-4. All-on-4 could be an all-on-5 or 6, or even more than that. In the maxilla, you might choose to place 5, 6, or 7, or 8 implants and do a hybrid. But as you'll see, the all-on-4 tends to have some specific requirements as far as angulations of implants and how the conversion process is completed. I think I know something about overdentures because I've done a lot of them, and a few years ago I also wanted to get out into the literature a consecutive set of cases that I had done, unsplinted overdentures, maxillary and mandibular. And a reason for doing that in the literature, in a peer-reviewed article, International Journal of Perio and Restorative Dentistry. One of the reasons I wanted to get that out is it's still controversial about doing unsplinted overdentures in the maxilla. You will still hear clinicians say, well, you better not do that. You better splint those implants together because maxillary bone is not as dense as mandibular bone, and some of the other issues with the maxilla versus the mandible. It's quite well accepted that we can successfully do unsplinted mandibular overdentures in most cases, or in many cases. Certainly there are indications where we would want to tie the implants together with a bar. Perhaps if implants are so widely angulated, we might want to put a bar in so we can parallel up our attachments. Or if we have such poor bone or such poor length and diameter of implants, we might want to splint the implants together. But in most cases, we will routinely do 4 implants in the mandible and do a locator type overdenture. In my study, I had 31 consecutive cases of mine. I didn't cherry pick any over a period of 15-year time period. So they were equally distributed between maxillary and mandibular. No failures, no implants failed. It's the typical complications, which are denture tooth fracture, denture base fracture, replacement of attachment housings, etc. But we didn't lose any overdentures, and we didn't lose any implants. So we know we can do it, recognizing that there are indications where we do have to splint. If I'm going to do an unsplinted overdenture case, these are, generally speaking, my preferred sites, cuspids and first molars, in order to get the AP spread as far apart as possible. You're trying to reduce the cantilevers as much as possible. So obviously in the maxilla, if we're going to place implants in about the first molar area, very commonly we're going to have to do a sinus lift. Very commonly in the mandible, we're going to have to do some buccal onlay grafting or even ridge grafting to try to grow the ridge as much as we can. And it's still hard to do to get vertical height built up in the posterior mandible. But if we are able to, those are relative to the sites that I'd like to have. I'd also like to have implants of at least, in the Noble BioCare system, at least 4.3 millimeters in diameter and 10 millimeters in length. And across the board with other implant systems, I would use a 4.0 millimeter implant whenever I can as a minimum diameter. I'll be quick to add, I don't always get that. So I can dictate to myself or to the surgeon, this is what I want, but what I get back sometimes will be a compromise. But this is where I'm going to start. And can we graft enough in order to get this? And can the patient afford it to be able to allow us to do that? That's a pretty good standard look there on the maxilla. Implants in about the cuspids and about the first molar sites. Even the second bicuspid site is just fine as far as I'm concerned. I've got enough spread here between the implants to give me good stability. And within the denture base itself, even though there's a pretty good bit of cantilever posteriorly here, that type of overdenture tends to work very well. Most of my maxillary overdentures are semi-palatless. So we'll cut out more of the palate than you see on this slide in most cases. We left this one in simply for phonetics. The patient actually sounded better with the palate covered than without it. And also, up until fairly recently, actually until the last couple of years, I always have reinforced my denture bases with a metal framework. That's a chrome cobalt casting that does not connect into the implants, but simply gives us some rigidity within the denture base. Because as we know, denture bases, denture acrylics will fatigue over time, particularly in the out years. 3, 4, 5, 6, 7 years out, we tend to see more and more cracking of the denture bases. I'm going to share with you a newer type of acrylic that is much stronger, much more breakage resistant than we had before. I think I debuted that here last year. And because of the increased strength of that acrylic, I may or may not put in a strengthening framework. The framework doesn't necessarily give you that much more immunity against breakage unless there's adequate acrylic thickness around that framework. So if we eat up too much of the denture base dimension itself with metal and only have a 0.5 millimeter of acrylic over it, you're still very likely to suffer some denture acrylic breakage. And I don't want us to minimize that problem, because when you get a number of these cases out in the field, overdentures and all on board, and if and when those start breaking, and I can guarantee you the odds are, just the law of statistics are, some of them are going to break. When enough of those break, it really becomes a practice management problem for you. So anything that you and I can do to minimize breakage, staining, just complications with hybrids and overdentures will help you in your practice and make things a lot less stressful for us. My backup, if I have to, is to bunch the implants farther towards the anterior, and I've had to do that in a number of cases. And many times the patients cannot or will not afford a sinus lift or a large onlay graft. And we have to go back to that terrible old statement, I'm putting the implants where the bone is. You know, I hate that when I hear that from the surgeon. Well, Sam, I have to put those implants where the bone is, and I know immediately it's going to be a problem for me when I hear that. But sometimes we have to do that in the real world. And actually, those cases have worked out okay. Ideally, I'd much rather have better AP spread than you see there, but sometimes you just have to deal with it. You also might consider splinting those types of implants with a bar and cantilevering the bar slightly with an attachment off of it. So again, the AP spread has a lot to do with the success of the entire case. And then what I call the package, and when I'm looking preoperatively, what is the osseous height and width, the osseous quality. We're going to get a pretty good idea from that today from our CBCTs. In the old days when we were doing panoramics, we certainly couldn't discern the bone density nearly as well as we can today. And then we've got to look at the patient's health history, and you are going to make some sort of decision how you're going to approach those kinds of categories that you see on the screen. The smoker and the diabetic. You know, are you going to place implants on the actively smoking patient? And if you are you going to set some guidelines? For example, the 2-pack-a-day smoker who admits to me that he or she is smoking 2 packs a day scares me to death. And in many of those cases, we will decline those patients because I know smokers lie. I used to smoke. You know, everybody that smokes lies. How much do you smoke, Mr. Jones? Oh, about a 1/2 pack a day. Translation, that's a pack and a half. So you have to kind of make your own decision. It doesn't mean that you can't successfully do implants on the smokers, but the risk factor is there. And the main thing I want to do is make sure that it's well documented that the patient has been advised that he or she is at least twice as much at risk for failure of their implants if they continue to smoke at all. Well, so what does that mean? Well, you know, we're into 97, 98% success rates at 10 years with implants in the non-smokers. So they're twice as much at risk. You know, maybe that puts it down to 95, 94, maybe 90 in some cases. It's still not terrible, but I would urge you to make sure that you have documented in your charting that you advise the patient of that risk factor if you decide to move forward with the case. Diabetics. Diabetics are generally pretty well controlled. Most of the patients I see are pretty well controlled medication or diet plans. Just kind of interesting along that line though, just recently I've had a patient, and I've had him for a long time, physician who's diabetic, and he's not well controlled because he doesn't control his diet well. He doesn't conform to the diet that he ought to. You would think in a physician he would. He works horrible hours. So his general health condition is not all that great. Thank goodness we're not having to put implants in him yet. But I do want to confirm that my diabetic patients are controlled, and I'll use my surgical colleague as sort of a backup on that as well. Osteoporosis. How are you going to deal with that? Which patients are you going to treat that have been taking bisphosphonates and which ones are not? And that controversy still goes on. It's not quite as much hysteria as it was a decade or so ago when we really realized this was a big problem. But there's a risk factor there, isn't there? And I bet you've already received some lectures or will on that very subject. Testing can be done. You know, the IV bisphosphonate patients are more at risk than the oral usage. Those have been on it more than 3 years or more at risk than less than 3 years. But still in all, you will need to come up with some sort of guideline for yourself. If you're like me, I work with multiple oral surgeons, and I have one oral surgeon I work with that will hardly touch the bisphosphonate patient. You know, I've got the little 85-year-old ladies that we've had to do root canals and cut the teeth off with the gum line because he won't take the teeth out. On the other hand, I've got another surgeon who's much more aggressive and will selectively take teeth out and then see how the patient responds. And if they respond well, we might even place implants. So again, there's a pretty good bit of wiggle room as far as how you're going to approach those particular types of patients. Immunologically, I've just put in, we're seeing more and more patients with rheumatoid, osteoarthritis, and other diseases that require the use of immunologically suppressive drugs. And we want to think about how much or little that's going to affect their ability to heal after implant surgery. Then you've got your kidney dialysis patients and your kidney transplant patients. You know, how are you going to deal with those? And actually, we've done those successfully. I'll show you a case on a kidney transplant patient that we did, but it required a lot of conversation between us and the nephrologist to allow us to place implants. Pre-surgical planning. Again, whether you're doing the surgery or you're doing it in conjunction, let's determine for sure how many implants we think we're going to place and where we're going to place them beforehand. I understand I'm probably talking to the church crowd here, but I can tell you that when I sit with an oral surgeon or a periodontist or a surgical specialist, one of their biggest complaints is I get referrals for implants from my GPs, and they just tell me, evaluate for implants. They don't get enough input from the GP, what kind of restoration they would like to have, fixed or removable, where we would like to have implants, and also a dearth of templates come from those corners sometimes. So obviously we want to find out where we're going to place them, how many, how much inner-arch space do we have? That's a big kicker. It's a very big decision to confirm in an overdenture, and certainly in an all-in-4, how much inter-arch space are we going to need, and are we going to have if we simply take teeth out without any ridge reduction? It's a very big problem when we don't remove enough bone for either of those types of prostheses, and we don't have enough room to place our overdenture or our all-in-4. And we will talk about that as we move through some of the slides. Pretty much the rest of that self-explanatory. Okay, so I would like to focus first with the overdentures and then move into the all-in-4 scenarios. I'll stop here for just a moment. Any questions? Okay. All right, so let's talk about overdentures. And instead of going into the traditional overdenture workflow, which is generally a 4, maybe a 5 appointment procedure, I want to share with you the newer technology that I've been working with in the last couple of years. And probably, maybe some of you all have already started doing this. But it cuts down this new workflow with digital dental work. Cuts down the number of appointments and also opens up to us the opportunity for stronger acrylics and scanning and computer usage to design our prosthesis. So we're going to digitally scan our impressions and our bite registrations. We might not even pour a model. In some cases we will, but we might not even have to pour a model in some of these. The entire case might be built and then milled from computer images. So that's a new journey that I've started out on, I guess about 2.5 to 3 years ago. And I'll just preface this that I don't have any financial interest in the company that I'm working with on this. That's Avident. Avident was the first digital denture company in the United States. There are a few other players here now, but Avident still has by far the greatest amount of data and also the greater options for us than any of the other digital arenas. Now, if any of you ever worked with Avident about 2010, 2011 when they started, anybody do an Avident denture? You did? Did you hate it? Huh? It was terrible, wasn't it? Yeah. So, and that's true. And I buzzed around that technology. Thank goodness I didn't do it at that time. But they didn't have their act together, really. Today, I think it's much different. But as a company, I know they're having to turn the corner to overcome some of this dissatisfaction. Because when I started getting interested in this and called some colleagues about their experience with Avident, it was all negative. The aesthetics was poor, the turnaround time was poor, the results were poor. It just wasn't very much positive about it. I'm just curious, did you do a denture or an overdenture? Denture. Okay. Okay, so having said that, I will tell you it is much improved over that period of time. And I would suggest that you take a look at that, whether it's Avident or Pala or some of the other players in the field. That technology is going to grow. It's only less than 5% of dentures and overdentures currently, but it will grow logarithmically over the next decade. Okay, so one of the things that drew me to milled denture acrylic, which would be the generic term that Avenant uses, is breakage. Now, we get by with dentures and overdentures in a lot of cases. I've got those cases that are out 15 years that have never broken. Nothing's happened to them, everybody's happy. But it doesn't take very many of those to start breaking and ruin your day. So breakage was the first thing that brought me to looking at milled technology. And I'll just go back and think a little bit about some of the complications that we see with overdentures. Dr. Charles Goodacre from Loma Linda did a seminal article with some others noting the complications with implants and prosthetics in 2003, and found that implant overdentures had the highest rate of complications, everything that you see here, including denture-based fractures. More failures on the maxilla than the mandible, that's probably not too surprising, particularly if implants are abused or the cases are abused and not put in properly, or if occlusion is off, or a host of other problems. What you're looking at here is a slide of milled denture acrylic versus the standard denture acrylic that you and I have worked with for 75 years. It is far less porous than standard acrylic because it is made out of a highly compressed cup of denture acrylic. It's still methyl methacrylate, PMMA, but it's highly compressed. So it becomes 8 times stronger than standard acrylic. It has less porosity, stain, or odor than standard acrylic. And those were the things that drew me to this technology in the first place. But then I picked up these other items. We get to participate in scanning technology of our impressions, as well as our bite registrations, and of our prostheses. I get what is called a digital preview, and I'll share that with you. The digital preview comes to me as a computer setup that I can view and rotate and look in many different angles and views. Those of you who do Invisalign or ClearCorrect, yep, the digital preview will look very similar, because that's very close to the preview that you get back on your Invisalign cases when you're looking at how all that's going to come together. It's not a big surprise because the people who developed the software for Invisalign broke off and became Avenant. Okay. And the accuracy of fit from milling. It reduces, or it basically eliminates that processing error that we have had. It's basically a one-to-one relationship from what I get with my impression as far as retention is concerned and what I get with retention with my denture. So if my impression snaps out and then I make a base plate that is milled and it has good retention, I know my final denture is going to have good retention. Again, because we eliminate that processing error. The other thing that has been nice for me is to be able to go from a 4-appointment workflow to a 3-appointment workflow if certain things align. And that basically is if the patient has a denture or an overdenture that I can use as make a duplicate of and use as an impression. So let me show you how we do that. The first thing you have to do, though, is you have to learn to make a duplicate denture. You know, I hadn't made one of these, a duplicate denture, in 20 years when this came up. My little Lang duplicator was down underneath the sink, right next to the surveyor with cobwebs on it.
Kill.